The objectives for this lecture are as follows. Describe the pathophysiologic mechanisms involved in nausea and vomiting. Describe pharmacologic management for patients at risk for postoperative nausea and vomiting. Nausea and vomiting in the postoperative period occurs in 20 to 30% of patients, and together are the second most common complaints reported. Pain is the most common. After the landmark 1992 review from Watka and White, postoperative nausea and vomiting became the more commonly used clinical term. And in 1999, PONV became a medical subject heading in the National Library of Medicine. The description of these symptoms as postoperative should not be construed to suggest that surgery is their most important direct cause, although this is a widely held belief. Several large prospective cohort studies now suggest that the varying incidences of PONV observed after different types of surgeries are largely a reflection of important patient-specific and anesthesia-related risk factors rather than surgery itself. PONV can be such an unpleasant experience that patients often rate it worse than postoperative pain. Prevention of postoperative nausea and vomiting in high-risk patients significantly improves postoperative ratings of well-being and satisfaction. While the experience of PONV is generally self-limited, postoperative vomiting and retching can lead to rare but serious medical complications, such as the aspiration of gastric contents, suture dehiscence, esophageal rupture, subcutaneous emphysema, or pneumothorax. PONV may delay patient discharge from post-anesthesia care units and can be the leading cause of unexpected hospital admission after ambulatory anesthesia. Annual PONV-related healthcare costs approach several $100 million in the United States alone. Nausea with or without vomiting is probably the most important factor contributing to a delay in discharge of patients and an increase in unanticipated admissions of both children and adults after ambulatory surgery. Patients hate vomiting. Studies have been performed in which patients are asked how much they would pay to avoid PONV or postoperative pain. Patients are willing to pay the most to prevent either of these outcomes, although the actual amount is a function, in part, on patient income. Women, especially those who are pregnant, have a higher incidence of PONV. Other risk factors include a previous history of motion sickness or post-anesthetic emesis, surgery within 1 to 7 days of the menstrual cycle, not smoking, and procedures such as laparoscopy, lithotripsy, major breast surgery, and ear, nose, and throat surgery. The greater the number of risk factors, the greater risk of nausea or vomiting after surgery. Inhalation agents are associated with an increased risk of PONV, particularly in the early stages of recovery. Postoperative narcotic use is associated with PONV more than 2 hours after surgery, but we will investigate these risk factors in more detail. The recognition of risk factors plays a critical role in making diagnostic and therapeutic decisions in medicine. The term risk factor was likely first coined in the Framingham study, where the risk of heart disease was associated with specific conditions such as hypertension, high cholesterol, and smoking. To know which of the risk factors is most likely causal or merely correlational can be critical for the development of a valid risk assessment tool to be used for clinical decisions. It is more useful to consider PONV multifactorial in its origin, that is, as a consequence of emetogenic agents applied to susceptible patients. A better prediction can be obtained by focusing on these well-established independent predictors that appear to cause PONV. Therefore, the following slides distinguish between risk factors that are merely associated with increased risk. Many reviews or book chapters list large numbers of PONV risk factors, irrespective of the evidence or magnitude of effect. This has contributed to a divergence between commonly held clinical beliefs about PONV risk factors and the published evidence. For example, Eberhardt and colleagues reported that over 80% of German anesthesiologists considered obesity to be a risk factor for PONV, yet Kroenke and co-workers found that an increased body mass index was not associated with an increased incidence of PONV. Similar discrepancies exist for the influence of face mask ventilation, the use of a nasogastric or orogastric tube, intravenous use of neostigmine to reverse neuromuscular blockade, the phase of the menstrual cycle, and even the weather or phase of the moon. Thus, the following discussion of risk factors for PONV will focus on these factors, which are well supported in the literature. Of course, other unknown or insufficiently studied PONV risk factors may yet to be found. For example, it may be possible that rapid patient transport from the operating room to the PACU, especially fast turns or decelerations, can trigger nausea and vomiting. Accordingly, the following discussion focuses on the best available evidence. We will take a look at the following risk factors: gender, smoking, history of motion sickness or history of migraines, age, anxiety, anesthesia-related factors, and surgery-related factors. Most prospective cohort studies using logistic regression analysis have identified the female gender in adults as the strongest independent predictor for postoperative nausea, vomiting, use of antiemetic rescue treatments, and overall PONV independent of anesthesia technique. Yet women have a lower threshold for motion sickness and for hyperemesis gravidarum. The reason for increased female susceptibility to nausea and vomiting is unclear, but persists well after menopause and most of the rest of a woman's life. Individuals often experience nausea and diarrhea when smoking their first cigarette. This is likely an acute effect of nicotine because nausea is a known side effect of nicotine patches. While one might predict that smokers have a higher risk of PONV than non-smokers, Cohen and others found that non-smokers were 1.8 times more likely than smokers to have PONV. These findings were subsequently confirmed by several, but not all, other larger-scale studies. The mechanism by which a smoking habit reduces the risk of PONV is not entirely clear, but one may speculate that chronic smokers are desensitized to nausea. Nicotine stimulates indirect GABA-mediated cerebral dopamine release, and nicotine withdrawal in the perioperative period may lead to low postoperative cerebral dopamine levels, reducing the activation of the dopaminergic circuits in the chemoreceptive trigger zone known to be associated with nausea and vomiting. Susceptibility to emetogenic stimuli varies among individuals according to history of PONV, history of motion sickness, and history of migraine. Although one would intuitively expect that a history of PONV is the strongest predictor for subsequent PONV, it is important to realize that this is not always the case. In fact, in the majority of studies, female gender is a stronger predictor than a history of postoperative nausea and vomiting. This is illustrated by a study of Outbell and others of 1,566 patients. About a third of the patients presented with a history of PONV, of whom every second patient experienced PONV. Two-thirds of patients did not have a history of postoperative nausea, of whom one-third experienced the postoperative nausea. Clearly, patients with a history of PONV were at higher risk for experiencing PONV. However, of the total 600 patients who developed nausea, fewer than half would have been correctly identified if the history of PONV had been used as a single predictor. Indeed, the use of PONV history as a single predictor has been associated with a sensitivity of less than 50% to identify patients at risk for postoperative nausea and vomiting. That is, fewer than half the patients who developed postoperative nausea were correctly identified in advance, which is less than one would expect from a random guess. In adults, although the incidence of postoperative nausea and vomiting decreases with age, it has not always been a strong risk factor. In children, however, Eberhard and others have shown that at an age of 3 years or older, there is an association with an increased risk of PONV. Anxiety may influence PONV, although this was not supported in a study with a small cohort of children. However, in secondary analysis of the considerably larger AIDA trial in adults conducted by the group around Kaufman, anxiety was assessed using 2 standardized psychometric instruments, and a statistically significant but fairly weak association was demonstrated. Although anxiety increases postoperative nausea and vomiting, a preoperative assessment of anxiety is unlikely to result in a significant improvement in the prediction of PONV. There are many things that we do to our patients that are likely to contribute to postoperative nausea and vomiting. One is our use of opioids. No large prospective cohort study has demonstrated that type or dose of intraoperative opioid influences PONV in adults. In children, the liberal intraoperative use of morphine is associated with frequent incidents of postoperative vomiting in children undergoing tonsillectomies. Whether the type of intraoperative opioid used is a relevant consideration remains controversial. One recent paper has suggested that alfentanil is associated with less PONV compared with fentanyl or sufentanil. Another group hypothesized that the ultra-short half-life of remifentanil would result in less carryover effect into the postoperative period and thereby decrease PONV. However, there was no significant difference in the overall incidence of PONV when remifentanil was compared with fentanyl, probably because the study design included predominantly larger operations requiring significant amounts of opioids for postoperative pain relief, masking any potential benefit. Finally, morphine 6-glucuronide, an active metabolite of morphine, has been reported to be associated with less PONV compared with morphine, although it was not statistically significant in another study. Most large studies using multivariable analysis demonstrate that use of postoperative opioids doubles the risk for PONV. As a consequence, opioid-sparing strategies should reduce the incidence of PONV. Indeed, postoperative nausea and vomiting tended to be decreased when cyclooxygenase 2 selective nonsteroidal anti-inflammatory drugs reduced opioid use by 20 to 40%. However, regional anesthesia definitely reduces the incidence of postoperative nausea and vomiting. Although this seems like a lot of contradicting studies, one thing does remain clear. The available evidence suggests that the dose of opioid, rather than type, is one of the main predictors or causes for PONV. Propofol is widely believed to have antiemetic properties. By using propofol in patient-controlled analgesia, pumps in the PACU as patient-controlled antiemesis, Gann and associates found that non-sedating plasma concentrations of 343 nanograms per ml reduced nausea in 50% of cases. However, using a similar design, Scuderi and others were unable to demonstrate any antiemetic effect of propofol. In another study, healthy volunteers were randomized to propofol, midazolam, or placebo, and then exposed to an infusion of apomorphine. At non-sedative doses, neither propofol nor midazolam provided protection. However, at sedative doses, both propofol and midazolam increased the threshold for nausea. As a result, the antiemetic activity of propofol-induced sedation is not clear. Compared with the purely regional anesthetic technique, general anesthesia is associated with a significantly higher incidence of PONV. This raises the question of the individual contribution of the drugs used for general anesthetics, namely opioids, inhaled anesthetics, and nitrous oxide. Although previous meta-analyses have demonstrated a lower incidence of nausea and vomiting with propofol compared with inhaled anesthetics in volunteer studies, an 8-hour anesthetic with sevoflurane was associated with nausea and vomiting in over 80%. This strongly suggests the emetogenicity of volatile anesthetics. In addition, a large clinical single-center study with patients demonstrated that the difference in vomiting between inhaled anesthetics and propofol occurs predominantly in the first 2 to 6 hours, and, more importantly, the difference in early vomiting is clearly dose-related, so that the difference is not due to propofol but rather related to the dose-dependent emetogenic effect of the volatile anesthetics. There are no differences in PONV among the volatile anesthetics, isoflurane, desflurane, and sevoflurane. This finding is consistent with a meta-analysis by Gupta and coworkers comparing propofol, iso, sevo, and des, a meta-analysis by Macario and associates comparing sevo and des, and a very recent study by Wallenborg and others comparing iso, sevo, and des. Numerous studies in the 1980s and meta-analysis in the 1990s emphasized the emetogenic effect of nitrous oxide. However, the emetogenicity of nitrous may not be quite as strong as that associated with volatile anesthetics. Moreover, the emetogenic effects of nitrous oxide and volatile anesthetics are independent, that is, they are additive. What is probably more notable than the emetogenic effect of nitrous is the recent landmark trial from the Australian group led by Paul Miles, comparing a nitrous oxide group with an oxygen-enriched air group, that found not only more PONV but also significantly more severe adverse effects such as pulmonary complications, wound infections, and fever in the nitrous oxide group. A second large multi-center study comparing a nitrous oxide group and nitrous oxide-free group is attempting to provide further evidence regarding nitrous oxide and the association with more severe medical complications. The effect of duration of anesthesia on PONV is described in a number of studies. As referenced earlier, the effect size may be large when inhaled anesthetics are used and small when propofol is used, and depend on the amount of opioids used. In any event, it is generally correct to assume longer and more invasive surgeries to be associated with more postoperative nausea. In fact, in a cross-validation that developed a simplified risk score, there was a collinearity between the duration of anesthesia and the postoperative intravenous use of opioids. Because intravenous opioid use was the slightly stronger predictor, that variable remained an independent predictor as opposed to the duration of anesthesia. Many surgeries are associated with a high incidence of PONV. This has led to many hypothesized causal mechanisms for various types of surgeries: tympanoplasty and vestibular stimulation, adenotonsillectomy and swallowed blood, breast surgery and emotional load, laparoscopic surgery and peritoneal irritation, abdominal surgery and serotonin release, and hysterectomy and vagal stimulation, all resulting in a tendency to narrowly specify the type of surgery in antiemetic trials. There is no question that patients undergoing large abdominal and gynecologic surgeries have increased risk for PONV, with incidences of at least 50%. However, in many instances, These cases may often be a reflection of other underlying factors. In this example, most likely prolonged exposure to emetogenic volatile anesthetics and/or large doses of intraoperative opioids. In fact, if volunteers are exposed to volatile anesthetics, even without any surgery for an extended period of time, almost all experience nausea or vomiting afterward. Therefore, risk assessment should be based on the underlying independent predictors rather than the type of surgery. In addition, several studies support the notion that the type of surgery is not an independent predictor for postoperative nausea, vomiting, PONV, or the need for rescue treatment. However, there are other studies that have identified several types of surgery as independent predictors for postoperative nausea, vomiting, or PONV. Nevertheless, most types have not consistently been shown to be independent predictors for PONV in the majority of studies. Possible exceptions to this rule are laparoscopic cholecystectomies and hysterectomies. Of note, although strabismus surgery is not a risk factor in adults, it is a well-established and clinically relevant independent predictor for POV in children. One might argue that it would be enough to know which types of surgeries are risk factors, whether or not they are independent predictors of PONV, to decide on the need for prophylactic antiemetics. The incidence of postoperative nausea and vomiting in many so-called emetogenic procedures, such as laparoscopy, adult strabismus surgery, middle ear surgery, etc., is not much higher than for other types of surgery. In fact, when Scuderi and colleagues stratified patients according to emetogenic procedures, the incidence of PONV in the PACU was 37% compared to 31% for all other surgeries, which is not significantly different. These findings are also consistent with a study in which PONV incidence over 24 hours was 42% for emetogenic procedures and 36% for other procedures. Although certain types of surgeries are associated with a more frequent incidence of postoperative nausea and vomiting, causality has not been clearly established. With the exception of strabismus surgery in children, the incidence of PONV with most surgeries likely reflects underlying patient and anesthesia-related factors. Postoperative nausea and vomiting is obviously multifactorial. Therefore, a patient's risk can better be estimated by accounting for several independent predictors simultaneously. Palazzo and Evans in the United Kingdom were the first who applied multiple logistic regression analysis to 148 patients undergoing minor orthopedic procedures, thus developing a predictive model for postoperative sickness. Koiviranta and colleagues were the first to publish predictive models for PONV based on logistic regression analysis and developed a simplified model by selecting the 5 strongest predictors: female gender, previous PONV, duration of operation over 60 minutes, history of motion sickness, and non-smoking. When 0, 1, 2, 3, 4, or 5 of these independent predictors were present, the risk for PONV was 17, 18, 42, 54, 74, and 87%. 1 year later, a predictive model for POV in patients undergoing ENT surgery was published that showed a tight correlation between predicted and observed incidence in a validation cohort. Because the latter model was developed in patients undergoing ENT surgery, its applicability for other types of surgeries was unclear. In a subsequent study that included a wide range of surgeries, type of surgery turned out to be an independent predictor at the expense of duration of anesthesia. The two groups then performed a cross-validation and found that risk scores derived from one center were able to predict PONV from the other center. The final score consisted of 4 predictors: female gender, history of motion sickness or PONV, non-smoking, and the use of postoperative opioids. If 0, 1, 2, 3, or 4 of these risk factors were present, the incidences of PONV were 10, 21, 39, 61, and 79% respectively. Understanding the various definitions and methodologies used in publication is critical for the interpretation of results. For instance, even though the occurrences of nausea and vomiting are correlated, they can occur independently and should therefore be assessed and reported separately so that the results can be compared across publications. This is true for both inhaled and intravenous anesthesia in both inpatient and outpatient procedures. Failure to realize this essential point has resulted in difficulties in assessing results for a significant portion of the available literature. Similar difficulties have arisen from the use of various scales that are generally inadequate to properly assess postoperative nausea and vomiting. For example, assessing PONV on a 4-point severity scale ranging from no symptoms to mild nausea to severe nausea or up to 2 vomits or more than 2 vomits fails to reflect the underlying physiology and presentation of these symptoms and does not allow determination of the proportion of patients experiencing nausea, vomiting, or both. Nausea, from the Greek word naudia, meaning seasickness, is often described as a sensation of unease and discomfort in the stomach with an urge to vomit. Nausea may present at different intensities, may last a variable period of time, and may be waxing and waning. There are 3 ways to assess the intensity of these symptoms. The most widely accepted measurement technique for intensity utilizes a visual analog scale, or VAS. The VAS consists of a 10-centimeter horizontal line with the left end corresponding to no nausea and the right end corresponding to worst imaginable nausea. Patients are asked to choose a point on the scale that represents the intensity of their current state. VAS is considered the criterion standard because its reliability and sensitivity have been well established in pain studies. Another common approach is the use of a written or verbal 11-point numeric scale, or NRS, with which the patient is asked to rate severity of nausea between 0 and 10, with 0 corresponding to no symptoms and 10 corresponding to the worst possible symptoms. The NRS approach has the advantage of ease of use and maintains a sensitivity similar to the VAS gold standard. The easiest approach appears to be a categorical verbal rating scale, or VRS, in which patients describe their symptoms as none, mild, moderate, or severe. Unfortunately, even though Buberetz and colleagues have demonstrated a good correlation between VRS and VAS for nausea, pain studies have found that the VRS is not as sensitive as the VAS. All told, the NRS approach may provide the best balance between sensitivity and ease of use. Usually the intensity of nausea varies over time, so that repeated measurements would be needed for an overall severity assessment. Thus, nausea assessment may not be accurate if the intervals between assessments are considerably longer than the duration of nausea episodes. As a rule of thumb, it might thus be advantageous to have patients estimate their average and/or severest level of nausea, rather than limit the patient to rating the current nausea at the time of questioning. Therefore, assessments of nausea should be performed covering a time interval rather than assessing a time point. Vomiting as a clinical symptom is the forceful expulsion of gastric contents through the nose or mouth. Retching or dry heaves is similar to vomiting with the exception that no gastric content enters the pharynx. An emetic episode is often operationally defined as 1 or more instances of vomiting and/or retching, separated by no more than 1 minute of respite. However, for the sake of simplicity, and because vomiting is much more frequent than retching, many authors' report of vomiting will include both vomiting and retching. In such instances, use of the term emetic episode is preferable. The measurement of vomiting and emetic episodes is simpler than that of nausea, because the former involves a distinctive and recognizable muscular reflex. Severity is therefore best evaluated by number of episodes, and recording of the times of each individual episode allows secondary analysis with regard to the time course. Because there is no universally accepted standard for how to measure and report nausea and vomiting, publication should at the minimum report separate instances of nausea and for vomiting, even if the primary outcome is a combined measure such as the incidence of PONV. Whenever possible, the frequency and success of rescue treatment should be reported as well, to allow comparison of treatment effects in subsequent meta-analysis. This may also be a reason why a joint severity score that considers the severity of nausea and vomiting may be a valuable adjunct to be reported and analyzed with more statistical power than the binary variables. Nausea and vomiting may be induced through various pathways. The vomiting pathway starts peripherally, where amirogenes through enterochromaffin cells in the gastrointestinal tract or the sensory neurons activate vagal afferents to the group of brainstem nuclei in the area postrema, the nucleus tractus solitarius, and the dorsal motor nucleus of the vagus. This area in the brain is otherwise known as the vomiting center. Although the pathways for vomiting are not completely understood, the area postrema is highly vascular, lacks a complete blood-brain barrier, and has receptors for neurotransmitters and hormones. Absorbed toxins or drugs circulating in the blood can cause nausea and vomiting via stimulation of the chemoreceptor trigger zone, or CRTZ. The CRTZ is located in the area postrema, a circumventricular organ at the bottom of the fourth ventricle. Even though the CRTZ resides anatomically in the central nervous system, its unique permeable endothelium allows it to detect emetogenic substances in the bloodstream as if it were a peripheral organ. Based on a series of papers, Borison and Wang were able to demonstrate in the early 1950s that the chemoreceptor trigger zone has an abundance of receptors and that its stimulation can send emetogenic triggers to the brainstem's vomiting center to activate the vomiting reflex. Although this mechanism explains how apomorphine, a fairly selective dopamine D2 agonist, provokes emesis, and why droperidol, a D2 antagonist, will reverse apomorphine's emetogenic effect, It remains unclear how the CRTZ senses or transduces emetic stimuli, and why nausea and vomiting are not typical side effects of dopamine infusions. Again, it remains unclear why certain receptor agonists circulating in the blood fail to trigger nausea and vomiting, while corresponding receptor antagonists prevent or reduce nausea and vomiting. The chemical receptors involved in transduction of signals in the area of the vomiting center and the area postrema include dopaminergic, cholinergic, histaminergic, serotonergic, and opioids. With so many pathways and different receptors, there is currently no perfect antiemetic. Neurokinin 1 may represent the final common pathway for PONV, and trials are underway examining drugs affecting this pathway. The vestibular system is another source of emetogenic stimuli, as observed in motion sickness or Meniere's disease. Motion sickness is a risk factor for PONV. Whether vestibular input contributes to the emetogenic state in the vomiting center, or whether anesthetics or opioid analgesics contribute to the susceptibility of the vestibular organ or signal processing is not clear. Ingestion of toxic substances like hypertonic saline or copper sulfate results in the release of serotonin from enterochromaffin cells in the gut wall. These enterochromaffin cells hold over 90% of the body's serotonin and appear to release it under various chemical and mechanical stimuli. Serotonin is secreted in close proximity to afferent vagal nerve endings of the gut wall that travel to the dorsal brainstem via the nucleus tractus solitarius. However, large amounts of serotonin released by neuroendocrine carcinoid tumors lead to flushing, diarrhea, wheezing, and abdominal cramps, but typically not nausea and vomiting. This finding suggests that serotonergic emetogenic stimuli are primarily mediated through the autonomic nervous system rather than the bloodstream. Therefore, even though renal secretion of 5-hydroxyacetic acid, a metabolite of serotonin with a much longer half-life, is associated with PONV after abdominal surgery, a causal relationship to PONV remains unclear. Data from multivariable analysis suggests that the main cause of PONV is exposure to emetogenic triggers, namely inhaled anesthetics and opioids. If both can be avoided, PONV incidence can be expected to be quite infrequent. In fact, a 5-year review of 1,264 cases using an opioid-free propofol ketamine sedation technique for a wide range of ambulatory surgeries under local anesthesia reported only 7 patients, less than 1%, with vomiting, and 21 patients, around 2%, requiring postoperative antiemetics. However, the lack of a control group in this study necessitates a cautious interpretation. Nevertheless, this result is in accordance with small-scale, high-quality randomized controlled trials, such as a comparison of anesthetic techniques by White and others. In that study, ilioinguinal hypogastric nerve block, spinal anesthesia, or general anesthesia with volatile anesthetics and opioids was associated with a PONV incidence of 7, 12, and 62% respectively. Although individual studies have been able to demonstrate a reduction in pain and/or opioid consumption by NSAIDs, most were unable to demonstrate benefits in their secondary outcomes, such as incidence of PONV. Bonnett's group conducted a quantitative systematic review of randomized controlled trials, and although there was insufficient evidence to demonstrate a significant reduction in pruritus, urinary retention, or respiratory depression, they were able to demonstrate a reduction of PONV of 30%. Although the efficacy of NSAIDs is not as high as that of regional anesthetic techniques, they are equal to antiemetics such as 4 mg of Zofran. Consistent with a low incidence of PONV after primarily regional techniques, with or without sedation, are the results of a meta-analysis by Liu and Associates that compared single-shot regional anesthesia, peripheral nerve block, or central neuraxial blockade versus general anesthesia as the primary anesthetic technique for ambulatory surgery. Patients who were randomized to receive a peripheral nerve block had a more than 4-fold lower incidence of nausea than those receiving general anesthetic, 6.8% compared to 30%. Similarly, a central neuraxial blockade was also associated with a numerically lower incidence of nausea, 5 versus 14.7%. Of note, anesthetic solutions for epidural anesthesia often contain opioids to increase the density of the block, which may be the reason why opioid-free paravertebral blocks are associated with the lower incidence of PONV compared with epidural analgesia. In this respect, intraoperative nausea and vomiting after spinal anesthesia is different. 2 large cohort studies of spinal anesthesia have been conducted and identified the following independent predictors for nausea and vomiting in the perioperative period: female gender, history of motion sickness, preoperative tachycardia, preoperative intravenous opioids, intrathecal procaine, use of phenylephrine or epinephrine, and hypotension or a high intrathecal block. Fortunately, Carlisle and Stevenson have created a comprehensive Cochrane review for all drugs that have been studied for the prevention of PONV. The first edition encompasses 737 studies involving 103,237 patients, the largest PONV meta-analysis to date and clearly the most important for clinicians seeking a single reference for drugs that may prevent postoperative nausea and vomiting. The drug classes that we will discuss are receptor antagonists, dopamine antagonists, antihistamines, anticholinergics, neurokinin receptor antagonists, and dexamethasone. Receptor antagonists, specifically selective serotonin antagonists such as Zofran, have been shown to have similar efficacy to help alleviate nausea and vomiting. Dopamine antagonists, antihistamines, and anticholinergic drugs are useful and are generally less expensive, but are associated with extensive side effects. Other therapies useful in controlling PONV include acupuncture, acupressure, supplemental fluid therapy, and clonidine, perhaps in part because it decreases anesthesia requirements. In one study, acupuncture therapy was effective in controlling both PONV and postoperative pain. Acupressure is most effective when it is administered after surgery. Acupressure bands or acupressure stimulation in the region of the P6 acupuncture point can help reduce post-op nausea and vomiting. When a relief band acu-stimulation device was compared with ondansetron for patients who were nauseous in the PACU after receiving Reglan or droperidol and undergoing laparoscopic surgery, nausea was most effectively treated with both the relief band and ondansetron, although both therapies were equally effective individually in treating PONV. Ondansetron was the first serotonin antagonist, and its introduction was a milestone in the prevention of early chemotherapy-induced nausea and vomiting. It was considerably more effective and had fewer side effects, no extrapyramidal symptoms or sedation compared with all previous antiemetics. Given its superior efficacy for chemotherapy-induced nausea and vomiting, it is not surprising that Zofran quickly established a reputation as the most effective antiemetic for prevention of PONV. The typical dosage is 4 to 8 milligrams given IV. This is comparable to the efficacy determined in meta-analysis of other antiemetics such as dexamethasone or droperidol. For example, in IMPACT, a large multi-center randomized controlled vectorial design trial, 4 milligrams of ondansetron, 4 milligrams of dexamethasone, and 1.25 milligrams of droperidol had risk ratios of 0.76, 0.76, and 0.74. That is, each drug led to a reduction of risk of about 25%. Of note, Zofran has a plasma half-life of 4 hours and is metabolized via CYP2D6, such that select genetic polymorphisms of the P450 enzyme can lead to decreased efficacy due to ultra-rapid metabolism. These polymorphisms may also be the reason why Zofran appears to be more effective when given at the end of surgery rather than immediately after induction of anesthesia. Ondansetron is regarded as the antiemetic with the lowest side effect profile. In pediatric patients where the extrapyramidal effects of the antidopaminergic drugs can be a serious problem, ondansetron is the first drug of choice. Side effects include headache, constipation, and altered liver enzymes. If patients have already received ondansetron prophylaxis in the OR and then are nauseous in the PACU, another repeated dose might not be effective. Based on a retrospective analysis of patients with nausea after receiving prophylactic ondansetron, established PONV was more effectively treated with promethazine than Zofran, and promethazine 6.25 milligrams intravenously rather than higher doses was most effective. More work is obviously needed to study effective therapies for treatment in the PACU. Dilazetron mesylate and its liver-converted active metabolite hydrodilazetron are other highly specific 5-HT3 antagonists with plasma half-lives roughly twice as long as Zofran. In general, all highly selective serotonin antagonists are considered to be equally effective when given at equipotent doses. For ondansetron, 4 milligrams is well documented to be the minimal effective dose, the minimal dose where any further increase fails to produce additional clinically relevant benefit. For dilazetron, the data from Cortelia and Associates suggests that 50 milligrams is superior to 25 milligrams and equivalent to 4 milligrams of Zofran. However, this contrasts to a pooled analysis of 3 trials by Philip and coworkers that suggests that 12.5 milligrams is the minimum effective dose, which is the dose approved by the FDA for the prevention of PONV. Granasetron is another highly specific 5-HT3 antagonist with a half-life that is about twice as long as that of Zofran. The FDA-approved dose for the prevention of PONV is 1 mg. This is based on a dose-range study from Wilson and Associates in which 0.1, 1, and 3 mg were associated with risk ratios for postoperative vomiting of 0.94, 0.56, and 0.66. A second dose-response study investigated the efficacy of 2, 5, 10, and 20 mics per kilo and found that 5 mics per kilogram appears to be the minimal effective dose, which corresponds to roughly 0.35 milligrams for a 70 kilogram adult patient. Despite results from these relatively large randomized controlled trials, some recent studies have again explored the possibility that doses as low as 0.1 milligram are effective for the prevention of PONV. One study compared 0.1, 0.2, and 0.3 milligrams with placebo in patients undergoing abdominal hysterectomies. Although all three doses were associated with less vomiting within the first 6 hours, no significant difference could be demonstrated over 24 hours. Of note, the majority of studies on granasetron suggested that 3 milligrams is superior to 1 milligram for the prevention of PONV, but those were published by a single center, and there have been serious concerns about the validity of the data. The current evidence suggests that the FDA-approved dose of 1 milligram is an effective dose for the prevention of PONV. Metoclopramide has been used for decades to prevent PONV. Its antiemetic properties are primarily mediated through its anti-dopaminergic action and prokinetic properties. In the past, use of large doses of metoclopramide, such as 200 milligrams every 6 hours, was a mainstay for prevention of chemotherapy-induced nausea and vomiting. Unfortunately, these large doses cause extrapyramidal side effects in more than 10% of patients, which can be treated with antihistamines and benzodiazepines, but are very uncomfortable. As a result, small doses of metoclopramide, like 10 milligrams, became established in clinical practice. However, this amount has not been proven to be clinically effective. Consequently, Wallenborn and Associates conducted a large, randomized, placebo-controlled trial comparing 8 milligrams of Decadron alone or combined with either 10, 25, or 50 milligrams of Reglan. The risk ratios for the prevention of PONV for these three combinations compared with dexamethasone alone were 0.89, 0.74, and 0.63 respectively. Thus, the efficacy of 25 or 50 milligram doses seems to be comparable to that of other well-established antiemetics. Efficacy needs to be balanced against the potential side effects. The most frequent ones were treatable hypotension and tachycardia, and the incidence of dyskinetic and/or extrapyramidal symptoms. Droperidol is a highly potent D2 antagonist with well-proven antiemetic properties at intravenous doses as small as 0.625 to 1.25 milligrams. Furthermore, it is similarly effective compared with ondansetron.
Compared with placebo, droperidol is associated with increased sedation, but with a decreased incidence of headache. Because of its relatively short plasma half-life of about 3 hours, it should be given at the end of surgery and at the lowest effective dose of 0.625 milligrams to minimize potential sedative side effects. For the same pharmacokinetic reason, the supplementation of a morphine-loaded PCA pump with droperidol appears to be a highly effective approach to reduce opioid-induced nausea and vomiting. Although 50 mics of droperidol per milligram of morphine appears to be the most effective dose, it was associated with sedative side effects, so the authors concluded that a dose of 25 mics of droperidol per milligram of morphine was optimal. Low-dose droperidol has also been reported to lead to anxiety, restlessness, and dystonia. A main reason for their rather infrequent use may be the sedative side effects that can delay recovery.
Diphenhydramine, or Benadryl, is a H1 receptor antagonist known for its effectiveness against motion sickness and relatively weak anticholinergic or antimuscarinic activities. Promethazine, or Phenergan, seems to have equal antihistaminic or anticholinergic properties, which poses a contraindication for patients with glaucoma and prostate hypertrophy. All relatively nonspecific histamine receptor antagonists have sedative side effects that may delay recovery when given immediately before the end of anesthesia. Side effects include drowsiness, urinary retention, dry mouth, and blurred vision. Promethazine has also been reported to cause vascular necrosis requiring plastic surgery of skin lesions and/or limb amputations, leading to the FDA safety alert in 2006. Data on the potential antiemetic properties of atropine are conflicting. For example, when co-administered with neostigmine to reverse neuromuscular blockade, atropine was associated with less postoperative vomiting compared with glycopyrrolate. One plausible explanation is that atropine, unlike glycopyrrolate, crosses the blood-brain barrier. However, comparisons of atropine versus placebo have been negative, perhaps owing to the drug's short half-life. Scopolamine is another central-acting anticholinergic or antimuscarinic that, like atropine, has a relatively short half-life. This limitation has been overcome by a transdermal formulation that allows a more favorable pharmacokinetic profile to cover up to 72 hours. Its antiemetic properties are well established for the prevention of motion-induced nausea and vomiting, and the scopolamine patch has also been shown effective for the prevention of PONV. Its long duration of action might be especially useful for the prevention of post-discharge nausea and vomiting in ambulatory patients. However, scopolamine is associated with an increased incidence of side effects, such as blurred vision, dry mouth, dizziness, and agitation. Useful for the treatment of motion sickness, opioid-induced vomiting, and PONV. Sedation, confusion, and dry mouth may limit its use. Dexamethasone is well documented as an effective antiemetic, and animal experiments suggest that it exerts its antiemetic effect through central inhibition of the nucleus tractus solitari, but not the area postrema. Most early studies were conducted with 8 to 10 milligrams of dexamethasone, but there is now convincing evidence from several smaller dose-response trials that 2.5 to 5 milligrams can be considered the minimum effective dose. Dexamethasone has a slow onset of action, which might be the reason why its application at the beginning of a case appears to be superior to later use. Rapid administration can cause an unpleasant burning in the genitals. According to Carlisle and Stevenson, direct head-to-head comparisons suggest its efficacy is similar to that of ondansetron or droperidol. Substance P is a regulatory peptide that binds to neurokinin-1 receptors found in vagal afferents in the gastrointestinal tract. More importantly, in the 1950s, it was shown to reside in areas of the central nervous system that are thought to be involved in the vomiting reflex. Nevertheless, it took over 40 years before it became apparent that NK1 antagonists could be highly effective against a wide range of emetic stimuli in animal studies. A few years later, Munch and colleagues showed the clinical feasibility for control of established PONV after major gynecologic surgery. The strong antiemetic property of NK1 receptor antagonists is confirmed by studies of aprepitant, the first drug in its class approved for clinical use by the FDA. In a 3-arm multi-center study, 4 milligrams of ondansetron given IV was compared with 40 milligrams and 125 milligrams of orally administered aprepitant. Although the incidence of nausea was similar between the groups, the incidences for vomiting were 26%, 10%, and 5% respectively. For the prevention of PONV, 40 milligrams of aprepitant is a dose approved by the FDA. However, it should be noted that although NK1 receptor antagonists appear to be superior for the prevention of vomiting, this may not be true for the prevention of nausea. And because novel drugs are inherently more expensive than generics, it is likely that the use of these drugs will focus on patients at high risk for PONV. Nevertheless, their excellent antiemetic profiles make NK1 antagonists ideal drugs to reduce the medical risk that may be associated with vomiting after certain procedures. Inspired by this, IMPACT, an international multi-center protocol to assess antiemetic combinations in a controlled clinical trial of factorial design, was developed. In this trial, 4,123 patients were randomly assigned to one of 64 possible combinations of 6 prophylactic interventions: 4 milligrams of Zofran or no Zofran, 4 milligrams of Decadron or no Decadron, 1.25 milligrams of droperidol or no droperidol, propofol or a volatile anesthetic, nitrogen or nitrous oxide, and remifentanil or fentanyl. Ondansetron, dexamethasone, and droperidol each reduced the risk of PONV by about 26%. Propofol reduced the risk by 19% and nitrogen by 12%. This study provided 2 major insights. First, it was demonstrated that all interventions acted independently of each other. All 3 antiemetics are similarly effective, and all 3 double combinations are similarly effective because there are no interactions. Second, it was demonstrated that the efficacy of drugs is independent of the patient's risk. As a consequence, the effectiveness is primarily dependent on the patient's baseline risk rather than the choice of antiemetic, and each addition of an antiemetic to a combination regimen adds less and less additional benefit as the patient's risk decreases. As an example, a female non-smoker without a history of PONV or motion sickness expected to require postoperative opioids has a PONV risk of about 60%. If she receives an antiemetic like 4 milligrams of dexamethasone, her risk will decrease to 44%, which means that the absolute risk difference will be 16%. Ginger is frequently assumed to have antiemetic properties, even though there are few studies, most of which are negative, and meta-analysis came to conflicting conclusions. However, based on data from a comprehensive review from Carlisle and Stevenson, there appears to be a lack of evidence for ginger to be an effective intervention for the prevention of PONV. Liberal crystalloid fluid supplementation was first described to reduce nausea by Chung's group. However, it is interesting that there appears to be little effect in the early postoperative period, while the effect becomes stronger in the late period. One could speculate that balancing out the preoperative fluid deficit reduces the need to drink larger amounts of water in the postoperative period, thereby reducing postoperative nausea and vomiting. Future studies may lend clarity. Various reports have investigated stimulation of the classic acupuncture P6 point, the 6th point on the pericardial meridian at the volar side of the wrist, for the prevention of PONV. As shown by White and Associates, this effect is comparable to that of conventional antiemetics. These positive results bring up the question of why P6 stimulation is only rarely used for the prevention of PONV. Because most studies were small, Lee and colleagues conducted a secondary simulation analysis that suggested that the effect for nausea, but not for vomiting, may be due to publication bias. Based on the published evidence, it appears that stimulation of the P6 wrist point by means of acupuncture, electroacupuncture, transcutaneous nerve stimulation, laser stimulation, an acustimulation device, and acupressure are effective measures for the prevention of PONV. In the United States, more than 60% of surgeries are now performed on an outpatient basis. In addition to being a major cause for delayed discharge and unanticipated admissions, PONV may also pose a significant problem to the patient after discharge. To date, the incidence of post-discharge nausea and vomiting has not been studied on a large scale, but a systematic review from Wu and colleagues suggests it to be 8% for emesis and 17% for nausea. Moreover, Carroll and colleagues found that 35% of patients were significantly distressed by post-discharge nausea and vomiting, such that it delayed resumption of their normal daily activities. Most patients await spontaneous resolution of symptoms without contacting their healthcare professionals for interventions or antiemetics. Thus, the magnitude of the problem has not been fully recognized as yet, and studies are ongoing to characterize patients at risk. Shorter-acting drugs are not as effective, especially when used at the minimally effective dose, and that antiemetics with a longer duration of action appear favorable. Therefore, dexamethasone, scopolamine, and the NK1 receptor antagonists may be reasonable first choice for the prevention of post-discharge nausea and vomiting. Of course, further studies, especially with the novel compounds, are needed to support this hypothesis. While numerous studies have investigated antiemetics for the prevention of PONV, relatively few have addressed their use for rescue treatment of established PONV. In fact, when Tramer and co-workers conducted a quantitative systematic review of rescue treatments for established nausea and vomiting, a total of only 18 randomized placebo-controlled trials met inclusion criteria. They reported an absolute risk reduction between 20 and 30%, consistent with the 20 to 30% reasonable risk known for the prevention of PONV in large trials. In fact, Scuderi and colleagues demonstrated that early rescue treatment of PONV results in outcomes including time of discharge, unanticipated admission, and time to return to normal daily activities that are similar to those achieved with routine prophylactic treatment. This finding, however, does not account for patient comfort, even though this might be difficult to measure in terms of patient satisfaction. Options for rescue treatment are interventions that have not been applied before, or where the half-life suggests that it is no longer active. Serotonin antagonists are not only the most commonly used antiemetics for prevention, but also the most commonly used antiemetics for rescue treatment. One reason may be that serotonin antagonists are currently the only class of intravenously available antiemetics that may have a rapid onset of rescue treatment while being without sedative side effects. Also, the addition of dexamethasone to dilazetron or haloperidol might increase the overall risk reduction for rescue treatment, again if it has not been given before. Finally, stimulation of the P6 acupressure point may be another option, given that its efficacy has been demonstrated for the prevention of PONV. With regard to dosage, early rescue treatment with 1 mg of ondansetron seems to have comparable efficacy and better effectiveness than 4 mg of prophylactic ondansetron. Dilazetron mesylate and its liver-converted active metabolite hydrodilazetron are other highly specific 5-HT3 antagonists with plasma half-lives roughly twice as long as Zofran. In general, all highly selective serotonin antagonists are considered to be equally effective when given at equipotent doses. For ondansetron, 4 mg is well documented to be the minimal effective dose, the minimal dose where any further increase fails to produce additional clinically relevant benefit. For dilazetron, the data from Cortelia and Associates suggests that 50 mg is superior to 25 mg and equivalent to 4 mg of Zofran. However, this contrasts to a pooled analysis of 3 trials by Philip and co-workers that suggests that 12.5 mg is the minimum effective dose, which is the dose approved by the FDA for the prevention of PONV. Granasetron is another highly specific 5-HT3 antagonist with a half-life that is about twice as long as that of Zofran. The FDA-approved dose for the prevention of PONV is 1 mg. This is based on a dose range study from Wilson and Associates in which 0.1, 1, and 3 mg were associated with risk ratios for postoperative vomiting of 0.94, 0.56, and 0.66. A second dose-response study investigated the efficacy of 2, 5, 10, and 20 mics per kilo and found that 5 mics per kilogram appears to be the minimal effective dose, which corresponds to roughly 0.35 mg for a 70 kilogram adult patient. Despite results from these relatively large randomized controlled trials, some recent studies have again explored the possibility that doses as low as 0.1 mg are effective for the prevention of PONV. One study compared 0.1, 0.2, and 0.3 mg with placebo in patients undergoing abdominal hysterectomies. Although all 3 doses were associated with less vomiting within the first 6 hours, no significant difference could be demonstrated over 24 hours. Of note, the majority of studies on granasetron suggested that 3 mg is superior to 1 mg for the prevention of PONV, but those were published by a single center, and there have been serious concerns about the validity of the data. The current evidence suggests that the FDA-approved dose of 1 mg is an effective dose for the prevention of PONV. In general, the use of prophylactic antiemetics is rarely justified when the patient's risk is low, like around 10 to 20%. The reason is the low effectiveness and unnecessary exposure to the possible side effects. However, as mentioned earlier, the use may be justified if this is a patient's preference or there are concerns about medical or surgical complications due to vomiting. For patients at moderate risk, 1 or 2 antiemetic measures are often appropriate, but these do not have to be antiemetic drugs. One approach could be a total intravenous anesthetic, or the use of 4 milligrams of Decadron, or both after the induction of anesthesia is supplemented with measures to minimize opioid consumption. For patients at high or very high risk, avoidance of general anesthesia and minimization of perioperative opioids may be the most effective approach. However, if a general anesthetic is needed, a TIVA with 4 milligrams of Decadron and an additional antiemetic can be recommended. Which partner drug to choose is most likely not relevant because most drugs appear similarly effective, and indirect evidence suggests that interventions with different mechanisms are additive, that is, they work independently. Of course, a TIVA could be substituted by an inhaled anesthetic with an additional antiemetic, but this eliminates one rescue treatment option should PONV occur in the PACU. This is particularly true for the use of a serotonin antagonist, which may otherwise be an effective rescue option without sedative side effects. The wealth of published information poses a challenge for the anesthesia provider to develop a comprehensive and valid strategy for the prevention and treatment of PONV. To this end, consensus guidelines have been developed. However, the fact that a group of individuals agree or compromise on a certain content or wording does not guarantee infallibility. Therefore, instead of summarizing various consensus guidelines, we will describe a rational approach for the prevention and treatment of PONV that is based on the current knowledge and understanding outlined in this lecture. This should be taken as a guide for clinicians, but not as a rigid rule, because there are certainly a number of other similarly valid approaches. To this end, the rule of 3 would be helpful. First, assess the need for prevention. Second, titrate preventative measures that includes a modification of the anesthetic technique according to the patient's need. And lastly, follow up on your patient and use of rescue treatment immediately by targeting mechanisms that have not been tried before. In conclusion, the ongoing need to improve understanding, prevention, and treatment of PONV is reflected in this literature. Over 2,000 randomized controlled PONV trials have been published in peer-reviewed journals, and almost 200 new studies are published each year. This is in part due to the interest of the pharmaceutical industry in developing new and more effective treatments for this condition. This more current understanding and knowledge will hopefully enable the provider to better manage PONV in daily clinical practice. None of the currently available antiemetics is capable of completely eliminating the incidence of PONV. Combination therapy is probably the most effective way to control postoperative nausea and vomiting. The best therapy possibly includes the avoidance of nitrous oxide, the avoidance of inhalational agents, the avoidance of muscle relaxant reversal if clinically indicated, the avoidance of narcotics, fluid hydration, the administration of a 5-HT3 antagonist, an antiemetic from a different drug class, and dexamethasone for patients at higher risk. Let's review some key concepts that are covered and applicable to this lecture. Postoperative nausea and vomiting may be triggered by various pathways through peripheral or centrally located receptors. However, the exact etiology is unknown. Numerous patient, anesthesia, and surgery-related risk factors are associated with a high incidence of PONV, but this association may not be causal. For example, the high incidence of PONV after gynecologic surgery is likely observed because the surgery is conducted in women, who are more susceptible to PONV and not because of the surgery itself. Instead of assessing a wide range of associated risk factors, a patient's risk for PONV is best predicted by a simplified risk score using independent predictors. In adult inpatients undergoing a general anesthetic, Apfel's simplified risk score includes female gender, non-smoking status, history of PONV or motion sickness, and the use of postoperative intravenous opioids as the main independent predictors. When 0, 1, 2, 3, or 4 of these factors are present, the risk for PONV is about 10, 20, 40, 60, or 80% respectively. In children, a similar simplified risk score exists for postoperative vomiting, or POV, with the duration of surgery greater than or equal to 30 minutes, age older than or equal to 3 years, strabismus surgery, and a positive patient history of POV or PONV in relatives as the main predictors. Because main triggers for PONV appear to be inhaled anesthetics and opioids, Strategies to avoid or reduce the exposure are effective means to reduce the risk of PONV. A PONV prophylaxis strategy should be tailored based on a patient's baseline risk, which can be determined using a simplified risk score. Patients at greatest risk will experience the greatest absolute risk reduction from interventions. Effective antiemetics to reduce PONV are cyclizine, dimenhydrinate, droperidol, dexamethasone, metoclopramide, ondansetron, dilazatron, tropazatron, and granasetron. Neurokinin antagonists are similarly effective against nausea compared with other antiemetics, but are considerably more effective against postoperative vomiting. While the minimally effective dose for prophylaxis with ondansetron is 4 mg, the minimally effective dose for rescue treatment with Zofran is only 1 mg. Based on this observation, it has been generalized that about a quarter of the prophylactic dose is needed for rescue treatment. Finally, a patient who suffers from PONV in spite of intraoperative prophylaxis with Zofran does not respond to rescue treatment with a second dose of Zofran or granasetron in the post-anesthesia care unit. It is therefore concluded that rescue treatment targeting an already blocked receptor is ineffective, so that an antiemetic strategy using a different mechanism should be instead used.